HIV Masterclass, and a warm welcome to all of you. Just to confirm that there are no conflict of interest, to declare, this webinar is particularly based on the South African National HIV Guidelines. And I'm going to be sharing as well some of the research from some of the articles, but you can be best assured that this particular session will be based on the highest level of evidence that is available. All right, so the chat is now disabled, and then all other questions, and particularly questions, please share them through the Q&A box in the platform. And I will continue to review and engage with you. Time and again, I will open the chat so that I can greet you and engage with yourselves. So the purpose of today's session really is to look at the South African HIV guidelines, because they were published a year or two ago, and there is a recommendation in the guidelines that a dolutegravir-based regimen should be our preferred first-line regimen. But now which we will discuss as part of this presentation, that you can also use DTG as part of second line. And this is for all populations, including pregnant women and those in the childbearing potential, irrespective of their fertility plans, or if they are pregnant, irrespective of any pregnancy trimester. However, there are controversies surrounding DTG, because as a country, at this point in time, we would have, wanted to have a big coverage of most of our patients on ARVs, to have been on a dolutegravir-based regimen. However, these controversies have actually, affected the rollout of the program. So as part of this webinar, we are going to evaluate some of the reasons, behind this. And I'm hoping that you'll be willing to share as well your views around, what are some of the barriers to DTG ART initiation. So I'm sharing a question with you. I've given you some ideas to say what are some of the barriers to DTG ART initiation. Is it the pregnancy-related factors? Is it the availability of drugs? Is it the drug-drug interactions? Does it have something to do with me and you not being very confident in initiating patients on ART? Are we seeing mostly children who maybe, are not necessarily suitable in your view? And then maybe we are doing all the work, and the challenge is probably recording and data-related issues. So yeah, so continue to participate. I'm going to keep this question open for another few seconds. And yes, I'm not sure why this thing stopped and started. May I be the only one who controls this for now, please? Thank you. Yes, go for it, colleagues. Go, 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 go. Interesting choices there. So I'm going to stop at this point in time. I know you all want to participate, but we have went beyond the allocated time for this question. And I'm sharing the results with you. And you see that around 35% of you are saying the challenge we have is drug-drug interactions. 25% of you saying, well, there's issues with DTG and pregnancy, followed by 21% saying, no, we are doing all the work as prescribed. The challenge we have is probably, with the recording and reporting. And I see very few of you believe that you lack the confidence And I see children and drug availability issues are coming through. So yes, let's then continue with today's session, and then I'm hoping that we will engage further at this point in time. So yes, in terms of today's webinar, our focus will be on the initiation of stable adults, on Earth. We are going to look at TB-HIV, co-infection, drug-drug interactions, pregnancy-related issues, side effects, pediatrics, and transitioning to DTG, or the use of dolutegravir in both first-line and second-line ART regimen. So I hope this would be exciting as I am. So we start and set the tone with a case. So here is Thabo. He is 31 years old. He's a male. He presents to you. He is HIV infected. He weighs 52 kgs and has a CD4 count of 120 cells. He does not have active TB or any other infections at this time. He is, however, taking cotrimoxazole without any side effects. So I'm asking you, a question. When you see a patient who presents like Thabo, what would be the drug combination, a combination of drugs that would form the basis of his proposed regimen? You are looking at different drug options. You have around 30 seconds to participate. Forgive me if you don't get a chance because we have to time the questions, but please continue. I see there's in excess of 500 participants, so I'm hoping that you will all get a fair chance to participate. If you don't get a chance to participate, please, you may even type your proposed regimen in the chat. I'm going to stop the poll and I'm going to show you your options there. So I see that 86% of you believe that Thabo should be initiated on dolutegravir together with tenofovir and lamivudine. And there's still a small percentage who say maybe abacavir is good, maybe zidovudine, or maybe efavirenz is a good option for Thabo. Do share your views why you believe your particular drug is key. But let me continue and share some information with you to say, when you are presented with a case like Thabo, you need to have a process or a systematic way of assessing and initiating ARVs for your patients. You have to ask how they are feeling, taking proper history, examining them, doing further tests for any problems that you identify. Don't forget to empower and educate, your patients. In terms of the initiation process, it's important to determine, the time frame. So Thabo, as we look at him at this point in time, is he a case, which we can initiate same day today, or do we need to delay ARVs? What type of drugs are we considering? Is he eligible for our standard first-line regimen, or he's been exposed to ARVs? Therefore, we should consider Thabo for second-line ART drugs. What are the best 3 drugs, which is what the question was all about, and if we need to be doing, any test. So today, I'm more focusing on the choice of drugs and not many other things. So if you look at Thabo's history, he is a stable HIV positive adult. In other words, he does not present with any obvious problems or complications. Therefore, we should be able to consider him for same-day ART initiation. If Thabo presented as a very sick patient with other opportunistic infections and some form of meningitis, we would then opt to maybe treat these conditions first for the first 4 to 6 weeks, and then taking it from there, initiating ARVs. But he is stable. Therefore, we want to initiate him same day. The second part is to say, has Thabo been on ARVs before? It's a question of yes or no. Our scenario sort of takes a position that Thabo is a newly diagnosed HIV positive patient. That means he has never been on ARVs before, and he should be eligible for our standard first-line ART regimen. If Thabo has been on ARVs before, you have to take proper history, you know, which drugs were you taking, you know, why did you stop, you know, and was it because you had a high viral load, or was it because you experienced side effects? Because that determines, you know, how you approach such a patient. If he stopped because of side effects, you want to consider a better, well-tolerable regimen. If he stopped because he had failed at that point in time, probably the standard first-line regimen is not a good choice. We might want to consider some of the second-line ART drugs. But in our scenario, Thabo is stable. He recently started he was recently diagnosed to be HIV positive. We believe that we should start him same day and probably on a first-line type of drug regimen. So when I say a standard first-line ART regimen, what are we talking about? We are talking about a combination, right? It's a fixed dose combination of drugs that has tenofovir, lamivudine, and dolutegravir. Most patients, 98%, if not 99% of patients that are diagnosed to be HIV positive patients are likely to do well on this regimen and might not have any obvious contraindications to this particular regimen. The advantage is that it's a fixed dose combination, one tablet once daily, you know, but it's very important that before you say, you know, you give it a green light and say, yes, I'm going to give what we call TLD, combination of tenofovir, lamivudine, and dolutegravir. You need to assess if there's any obvious contraindications to tenofovir or dolutegravir. And this is where, you know, usually we get stuck a bit, right? So TLD is our preferred standard first-line ART regimen because it has benefits that are a bit superior to what TEE. Now, when you see TEE, it's the same as TLD, except that the dolutegravir component there has been replaced with efavirenz, right? Now, TLD is preferred because it provides, you know, rapid time to viral suppression. So if you've got a patient who presents with a very high viral load, they are likely to suppress quicker if they are on a dolutegravir-based regimen versus an efavirenz-based regimen. It is generally well tolerated. That means patients don't stop it. They don't experience a lot of side effects, or if they do, these are mild. It has a high barrier to resistance. We don't expect our patients to be failing. And it has a limited, if no, you know, important drug-drug interactions with our hormonal contraceptives, which is quite a valuable feature of this particular drug combination. On the other side is that there are drug interactions you have to pay attention to, and we will discuss some of the side effects and how you can approach patients who present with those kinds of challenges, right? So TEE is still there. It is a good regimen. You know, fortunately, efavirenz is the weakest link of this particular regimen, making it to have a low barrier to resistance. That means patients can fail a single point mutation K103N can render the whole class ineffective, you know, with high level resistance. There's significant neuropsychiatric side effects from horrible dreams to poor concentration, you know, insomnia, sometimes even suicidal ideas and depression. So this is quite important. The drug interactions with contraceptives, very key. You know, on the positive side, efavirenz can easily be prescribed with TB treatment without worrying about drug-drug interactions. So this is quite key. And this is the rule, you know, all regimens so far, I know the world is changing and at some point we might be using 2 drugs, but as I speak to you in terms of our South African guidelines, we treat HIV with 3 drugs, 2 NRTIs and a choice between your integrase inhibitors, which would be dolutegravir in this instance, where dolutegravir cannot be used because we have some drug-drug interactions that are significant or for whatever reason, then efavirenz is a second choice. So in other words, efavirenz is not our preferred drug of choice for newly diagnosed patients, but for patients where DTG cannot be used, therefore we opt for efavirenz. And where both are absolutely contraindicated, then lopinavir, ritonavir becomes a choice. Where TDF cannot be used, usually because of renal impairment, we can then opt to transition our patients to an abacavir-based regimen and maybe a zidovudine-based regimen if we have no access to both TDF and abacavir. So our standard first-line regimen for adults in South Africa is a combination of tenofovir, lamivudine, and dolutegravir, and this is what we call TLD. There are instances where tenofovir is contraindicated, therefore we would shift to use abacavir with lamivudine. Usually these two you can give as a fixed dose combination together with dolutegravir, and I know that we might be getting an abacavir, lamivudine, dolutegravir fixed dose combination, which I think is going to be quite an exciting experience when we get there, right? In an instance where there are some reasons why you cannot give dolutegravir, you may then give efavirenz. And I tell you, the single most important issue is usually drug-drug interactions. But you have to pay attention because most of the drug-drug interactions that affect dolutegravir may also affect efavirenz. So it's quite important that you must have your formulary and you need to know exactly, what is it that you are doing there. So in other words, where we have issues with DTG, we have an option to use efavirenz or lopinavir. And drug-drug interactions are the enemy of most drugs, including DTG. So we have to pay, significant attention to these particular drugs. Now, here's a meta-analysis of 20 studies confirming that DTG is quite a superior drug. A superior drug, because in this instance, it was not only compared to efavirenz, but it was compared with some of the second generation NRTIs, rilpivirine, copistat, some of your integrase inhibitors, raltegravir, bictegravir, and also some of our PIs, atazanavir, lopinavir, and duranavir. And I see you smiling there. You are saying, yeah, I got him today. Well, these names are not English, right? So you need to practice with me because the world is changing. But, as part of this meta-analysis, these are the outcomes, and I designed this table to make it easy for you to say, when you compare dolutegravir to all these particular drugs, dolutegravir is able to deal with patients, if you look at the bottom there, who present with high viral loads, especially if the baseline or initial viral load of your patient is in excess of 100,000. Now, you would know that in South Africa, we don't do baseline viral loads, but the assumption is most patients, when they start ARVs, they have high viral loads. If you see a patient who's got a CD4 count less than 200, DTG is your response, is your intervention, because in terms of the increase of the CD4 count from baseline, it compares to none of these particular drugs which it was compared with. So this is quite important. And in the DTG arm, you have fewer patients who stop or discontinue the drug because of tolerance or side effects, and very few patients would experience severe, adverse events compared to other drugs and what they're able to do. So DTG is superior. Remember, the topic is about TLD versus TEE, and the difference between TLD and TEE is whether when you, as a health professional, initiate a patient on ART, are you opting for DTG or other drugs, right? And here I'm saying to you, if Dr. Mawela wakes up tomorrow, he's positive and he's got a high viral load and a CD4 count of 2, what is the best drug combination for such a patient? It is a drug regimen where the foundation of that regimen is dolutegravir, and you can check the studies there as published, right? So let's continue with our scenario, Thabo. So at this point, we agreed that Thabo should be initiated on TLD. So he comes back to you 7 days later and he says, I went to my local GP, and my local GP, you know, he diagnosed me to be having TB. So now that you initiated Thabo 7 days ago, and he's coming back now, and Thabo has TB, you know, how does this affect your regimens? What changes would you propose for Thabo at this point in time? All right, I'm gonna give you 30 seconds to look at your options. I'm also going to open the chat a bit so that if you want to make your comments, you may make your comments in the chat. All right, interesting. Right on. Hey, you guys are voting. You should see these numbers going up. There's a 600 of you or more. Already 400 of you have voted. So this is quite exciting as well. I must appreciate your attendance. It means as a platform, we continue to add value to you. So I'm going to stop there and then maybe share the results with you. And I see there's 3% who say I will stop the ARVs and wait until TB treatment is complete. I tell you what, if you do not treat both HIV and TB at the same time, your patients might not even complete the TB treatment there. Switch dolutegravir to efavirenz. Yeah, you know, you might have a point there. You might have a point. I mean, efavirenz works best with TB, but you know, that does not make efavirenz more superior than DTG, and you are interrupting a stable regimen that your patient is already on. And remember as well, in South Africa, we have a pre-treatment resistance prevalence in excess of 25%. So if you have 4 patients, every first patient, every 4th patient, basically, that you initiate would have developed high-level mutations already against efavirenz. And that means some patients on efavirenz will never suppress, even if they've never been on efavirenz before, because they would have received these mutations from their sexual partners. That option there, the third one, where you say increase DTG to 50 milligrams BD, is probably the best option at this point in time. And switching to lopinavir is quite complex with a lot of tablets. I think your patient would be very unhappy with you at that point in time. So yeah, so I'm continuing from here and saying, so if now Thabo has TB after initiating ARVs, I mean, ideally we want patients we want to diagnose TB first, right? Allow your patient to take TB treatment for 2 weeks, then start ARVs. But unfortunately, in this instance, he presents after we have started ARVs. We are not going to interrupt those particular ARVs. We must just start TB treatment. In this instance, we will start it immediately, then monitor our patients very closely and see how far we go, you know, with the patient. If she does well, we don't need to act or do anything. However, if we had diagnosed TB before, we would then look at the CD4 count of our patient. If she has TB with a CD4 count less than 50, we would then continue TB therapy for at least 2 weeks, then start ARVs then. If she has a high CD4 count higher than 50 and she has TB, we start TB treatment. We allow the patient to take it for 2 to 4 weeks, then start the ARVs later on, which is key. Now, what is the interface between TB treatment and ARVs? And you would see that our NRTI, so tenofovir, lamivudine, abacavir, zidovudine, there is no drug-drug interactions between those drugs and your TB treatment. So we don't need to do any dose adjustments. However, Thabo, our case, has been prescribed a dolutegravir-based regimen. Now, rifampicin is a liver enzyme inducer, so it will always increase or fast-track the metabolism of other drugs that are metabolized by the same enzyme, including dolutegravir. And you would see here that in this context, we would have to increase the dosage of dolutegravir from 50 milligrams daily to 50 milligrams 12 hourly, which is quite important. Efavirenz, like I said, some of you said, let's switch to efavirenz. I said, well, it's neither here nor there, but I gave you reasons why I wouldn't switch my patient from DTG to efavirenz, though efavirenz is a safer option in terms of drug-drug interactions with TB treatment, but it's got a low barrier to resistance and it's got more side effects, your neuropsychiatric side effects, and then importantly, I spoke about the pre-treatment prevalence of a drug resistance in the country, that up to 25%. So some of your patients that you give efavirenz would fail. It doesn't matter how adherent they are because they have been infected with a virus that has mutated. So it is safe, it is good, but there's other things to think about. Nevirapine is a no-go area, so never give nevirapine with TB treatment. It's a stop nonsense, red stop, don't do it. And we've got lopinavir, ritonavir. So if he was on this regimen, we would need to either super boost, by prescribing additional ritonavir or even by doubling the dose if we are prescribing tablets. So our focus area is on line 2 there, where DTG is increased. So basically, our patient is already taking TLD. So let's say he's been taking his TLD at night, right? And now he develops TB. You tell your patient, continue taking TLD at night. Then you prescribe dolutegravir 50 milligrams to be taken in the morning. So your patient takes dolutegravir 50 milligrams in the morning, and then the combination tablet TLD in the evening, and then you should be able to do well with your patient at that point in time. So yes, I see someone says any use of nevirapine, Leseho. I think I've answered that. Nevirapine is not going, to work in this instance. How to manage patients complaining about weight, blessing, it's coming, be patient on that one. And then when do we give dolutegravir to patients newly diagnosed with HIV? Yes, Arthur, when immediately. So if your patient is stable and there are no obvious contraindications to dolutegravir, it should be your immediate choice as a fixed dose combination with tenofovir and lamivudine. Keisha, let me do this. Keisha, Vincent, you are saying, what about using lower dose efavirenz? Yeah, that's a move. And we know that the lower dose efavirenz is as effective as a higher dose efavirenz, the 600 milligram. You get fewer side effects, but it cannot be used with TB treatment, right? So if you are using the lower dose efavirenz, not with TB treatment, and then importantly, Keisha, in our current guidelines, the public sector, I think even the society's guidelines, we have not yet recommended the use of a low dose efavirenz, but I think there's a place for that, because at the lower dose, you are going to get less side effects. Hepatitis, we won't discuss today. And then why take TLD at night? Galula, TLD can be taken anytime, in the morning and at night, right? I was just giving a scenario in the context of how do you prescribe a DTG 50 milligrams BD? Now, you must remember now your patient is already taking TLD. If she was already taking TLD in the morning, they continue to take it in the morning, then you add your additional 50 milligrams at night, and that should be quite helpful right there. Right, I've just answered a few questions, but we have to continue teaching, so I'll keep on checking that side as well. So here's some science behind some of this. If you are worried that maybe DTG will not do some good job in compared to efavirenz. So here we are looking at a comparison between a dolutegravir, which is it black or dark blue there? I'm colorblind because I'm wearing screen glasses. So yes, we are comparing a dolutegravir based regimen, and I can tell you here they used a DTG 50 milligrams BD, and we are comparing that with efavirenz 600 milligrams BD. And you can see that early on, patients who have TB and HIV would have high blood levels of DTG, but at the end, the effectiveness of the two drugs is quite comparable. And one might say, well, it seems like efavirenz is doing well compared to dolutegravir, but the reason there has got nothing to do with patient level, clinical outcomes. It has something to do with a number of patients who defaulted or discontinued. There were no deaths between the two groups. There were two discontinuations, particularly on the efavirenz side because of side effects. And there were 3 protocol-defined virological failures, 2 from DTG, and not because of acquired resistance, but more from the transmitted mutations, which were picked up before these patients even started ART. And you see that there was 1 treatment failure from efavirenz. And if you look at the conclusion from these studies, that amongst patients who were included in this particular study receiving a rifampicin-based TB treatment, DTG twice daily was as effective and well tolerated as efavirenz, right? So it's quite important that you appreciate that even in the context of TB-HIV co-infection, DTG will still give you the kinds of clinical outcomes that is expected. Controlling TB, but also positive TB outcomes and good clinical outcomes from the HIV management component of this treatment. This is a different study, but what I want you to look at, because it's a combination, it's a comparison of dolutegravir and the patient who's on an efavirenz-based regimen. That's why we call it a non-DTG regimen. These patients have TB and HIV at the same time, and the conclusion is that DTG is non-inferior. You get comparable treatment outcomes in terms of TB success, the proportion of patients who go and complete TB treatment or even get cured. And if you look at the proportion of patients who became eventually suppressed, was actually quite good comparing the two of them. And it's important that that in this study, I think it was in Botswana, if I'm not, yes, it was in Botswana, in the DTG arm, they had patients who had TB, HIV, who were given DTG once daily, and some of them were given a BD, so the once daily could have had some level of effect in terms of the outcomes of patients who are on a DTG-based regimen. But overall, the conclusion is what? Is that the use of DTG-based ART regimens in patients co-infected with TB and HIV leads to favorable TB and HIV treatment outcomes. So both programs, the TB side and the HIV side, they should be quite happy for us to continue DTG in the context of TB treatment. Remember, in the South African guidelines, we use 50 milligrams 12 hours. We do not continue the daily dose in patients who have both TB and HIV co-infection. So I'm hoping I'm answering some of your questions. And I found this study, very interesting, and it underpins why the clinical care platform is such a valuable platform for you, and for me, because they looked at South African health workers' knowledge of dolutegravir's drug-drug interactions in the first year of rollout. So they looked a year later after the guidelines were changed in South Africa, and you can see they had around 2,000 responses from health workers. 41% were nurses, 35% were doctors, and around 9% were pharmacists. And what you see is that the knowledge of specific drug-drug interactions was quite low, right? Particularly for things like calcium, you won't see it there, but where both answers were correct, that means all the questions asked about calcium were correct. Only 5% of the 2,000 health workers actually knew how to approach a patient who's taking dolutegravir and calcium. You can see again, iron, it's not, you can't even see this 5.7%, 10% in terms of, I don't know why the poll is sharing back. Let's not do that. 10% knew how to identify and manage Tegretol or carbamazepine related, the strength was on the TB-HIV side. So it means in the HIV and TB program, we do emphasize a lot about TB-HIV integration, but it's important to know that about 20% of these health workers did not know how to manage patients who have TB and HIV at the same time. So this is quite crucial, and drugs like aluminum or your myogels, your anti-acids, some of your antidiarrheal drugs, may interact significantly with DTG. And if me and you are not paying attention to this, we might have a lot of problems. And then you see here, access to guidelines and training, like what we are doing today, was in this particular study, was positively associated with improved knowledge and practice from health workers. And the conclusion was that there are gaps in their awareness and knowledge on dolutegravir interactions and how to adjust dosing amongst South African health workers. Hence, this topic and this platform becomes very, very crucial. Remember the key themes, right? We said how to initiate a stable patient. TLD is the best. Now, we moved on and said TB-HIV integration. We looked at what the guidelines says, but also we looked at the evidence to support that DTG remains effective even in the context of TB treatment, as long as you adjust the dose and you make it a 50 milligram 12-hourly dose. And you can see there, if your client is on a fixed dose combination TLD, they just continue taking their TLD as prescribed, and then you prescribe the additional 50 milligrams either in the morning or evening, depending on when they are taking their TLD. Don't forget that there's other important drug-drug interactions which may lower the blood levels of DTG significantly. So your patients who are epileptic or who are taking some of these drugs to manage nerve pains and other neuropathic pains and so on. So you have to be very cautious. And the first thing is to avoid co-administration. Try to use second and third generation anticonvulsants. And if you are not winning in that space, maybe consider then increasing the dose of DTG in that context, or even using safer ones like Epilim, sodium valproate, which has minimal drug-drug interactions with dolutegravir. In the context of diabetes, we know that the DTG increases the blood levels of metformin significantly, sometimes to toxic levels. So your patients might come back sick, but also with hypoglycemia if you are not very careful. So if a patient is taking in excess of 500 milligrams 12-hourly, you also need to consider whether DTG is the best drug for that particular patient at that point in time. Don't forget the calciums, the ions, they attach to the drug, they form complexes, in the intestines. Rather than these complexes being absorbed in the blood, they are going to be excreted with the feces. So you want to really know how to manage such drug-drug interactions. And you can see here, if you prescribe a dolutegravir-based regimen with either calcium or iron without food, the DTG levels are going to drop significantly. Your patient will be on dual therapy and most likely develop a significant mutation. So we don't want that, right? However, food is a good thing, because if you say take DTG with calcium after you have had your meal, immediately after you have had your meal, there's no effect. So your patient will get good drug levels. But remember, calcium and ions cannot be taken at the same time. They must be taken at least 4 hours apart. So in pregnant women, you would say, well, take DTG with calcium and food in the morning, and then maybe during lunch or later take your iron supplements. That is quite key. Lastly, antacids regardless of food. So if your patient is taking Myogel, Spasmogel, Gaviscon, whichever they are taking for heartburn or dyspepsia, they cannot take DTG and either antacids at the same time, whether with food or not. Therefore, the spacing needs to be done. So rather take DTG 2 hours, before you take your supplements. If they wake up and start with antacids because maybe there was severe pain, then the DTG should be taken 6 hours later, right? These are important drug-drug interactions that may affect the effectiveness of our ART regimens. So I hope you are with me. Can you type in the chat box there? I don't like teaching alone. How are you doing? Are you following? Are you enjoying the session? I've opened the chat just for a few minutes, just for you to share with me there, to say, okay, we are following. You are not alone. When you teach virtually, you don't see the class sometimes, right? So yeah. So I'm about to also address another important issue. Let me answer 1 or 2 questions in the chat there, and then we will continue from there. So in the absence of DTG single agent in the facility, can I opt for lopinavir/ritonavir? Yeah, Tiva, I think you might want to go for efavirenz, right? Because lopinavir/ritonavir is good, it's effective, but in the context of TB, it's a lot of tablets. Remember, before if you prescribe it and your patient does not have TB, they will be taking 2 big tablets the size of my thumb twice a day. So the frequency again is also a challenge. Now, in the context of TB, you're going to prescribe 4 tablets twice a day. And the side effects, the watery diarrhea, the elevation of the cholesterols, syndrome X, cardiovascular, high cholesterol, a high BP, insulin resistance leading to diabetes. So lopinavir/ritonavir would be your option if both DTG and efavirenz, you have no access to both. That is what you might want to do. Sibonisile, you are saying there the patient completed TB treatment, he or she was on TLD. When to stop the added? Yes, so you have around 2 to 3 weeks, right? Remember, once you stop your TB treatment, the enzymes remain revved up for at least 2 to 3 weeks. So you have to continue your super or your boosted TLD for at least 2 to 3 weeks. And then you can stop from there. So that is quite important there. Sponisile, I hope I've answered that. I'm continuing now with another important topic. So in my evaluation of some of the reasons why in certain districts and provinces, we might be having slow uptake of DTG, it's because in certain districts, we are having access to this, what we call short course TB preventative treatment, and it's called 3HP. The 3 there means it's TB preventative treatment that is taken for 3 months, a combination of high dose INH and rifampicin, so it's preferred because it's taken once weekly for 3 months. So if the patient basically gets 12 doses and you get the same efficacy as 12 months of INH. So in districts like Ehlanzeni in Nelspruit, in Mpumalanga, city of Joburg in Gauteng, eThekwini in KZN, OR Tambo in Eastern Cape, and Cape Town, 3HP is available. And the health workers love it, right? And because you love it, you want to give it to all patients. Now, you are doing the opposite. You are prioritizing a prophylaxis therapy over ARVs. It should not be like that. Your first step is to assess your patient, choose the best ART regimen for your patient. If for Dr. Mawela, the first preferred ART regimen is TLD, give Dr. Mawela TLD, right? Don't say, no, I'll give 3HP, and then because 3HP has drug-drug interactions with DTG, then I give my patients efavirenz. You have short-charged your patient. You are giving your patient a less efficacious drug combination because you are prioritizing this miracle of TB preventative therapy. Okay, so quite important, for you to understand. So number one, there is a drug-drug interaction between dolutegravir and 3HP, particularly the rifampicin component of 3HP. Now remember, rifampicin, rifampicin, they are both rifamycins. They both are able to activate your liver enzymes and metabolize other drugs quicker, like dolutegravir. So I'm going to explain that. So DTG blood concentrations are significantly lowered by 3HP, up to 50%, right? But we know from other trials that DTG is such a potent drug that even at 50%, it can still be effective. And in other studies, patients who were even given DTG 10 milligrams as a daily dose were able to fully suppress. But we cannot reduce clinical decisions, by extrapolating from other trials. We have to wait for specific trials that are assessing 3HP and DTG so that we are able to know exactly what is it that we need to do. So in essence, if a patient has been initiated on TLD, they are not a candidate for 3HP, right? You would rather give INH for 12 months. And I know patients will fight with you to say, but why 12 months if I can complete this in 3 months' time? But we cannot take the risk because ultimately your patient might fail ARVs. Also, when you transition a patient from efavirenz to a DTG-based regimen, now very important, remember, you have a patient who was taking TEE, they are virologically suppressed, right? You transition them to DTG and you think, well, can I give 3HP? Because this is not a newly initiated patient, right? Be cautious. Remember, efavirenz, when you stop it, it has a long half-life, right? You're going to have, when you transition patients from efavirenz to DTG, right? You still have residual efavirenz, which continues to activate the liver enzymes and lower your DTG levels, though this is not clinically significant. But what is it that you are trying to avoid? You are transitioning a patient from efavirenz to DTG. Efavirenz lowers the blood levels of DTG, but it is not an important reduction. What if then you add 3HP on top of that, right? So during the transition, you realize that Dr. Mawela was never on a TB preventative treatment. Now you are saying, oh, let me give him 3HP. You are doing a double lowering of DTG. Firstly, by the efavirenz that you are stopping, and secondly, by the rifampicin component that you're going to find in the 3HP. So what is the recommendation? If you see a patient, Dr. Mawela, tomorrow, who's taking TEE, an efavirenz-based regimen, they are fully suppressed, and you are transitioning this patient, but the patient has never been on TB preventative treatment, what can you do? You transition them to DTG, you wait for 2 weeks. After 2 weeks, you can start them on a 3HP regimen. They will take it weekly for 12 weeks and complete the TB preventative treatment. So you wait for 2 weeks as the minimum. Right, I hope that is clear. So I've summarized it here because some districts, this is new to you. You have never heard of 3HP. You only know that in the country we practice INH monotherapy. Well, there is a new short course TB preventative treatment, a combination of high dose INH and rifampicin for a newly diagnosed HIV positive client where a clinical decision is made to start this patient on a DTG based regimen. 3HP must be avoided. Please provide INH prophylaxis for this group of patients, right? If for whatever reason an efavirenz-based regimen is the preferred regimen based on clinical things and drug-drug interactions, then it's fine. Efavirenz and 3HP, no significant drug-drug interactions, and you may continue as such, right? For a treatment experience, now we're talking about transitioning. If a patient is on an efavirenz-based regimen, right, you can start 3HP anytime. A patient on a DTG-based regimen, you can start 3HP only if there's evidence of virological suppression. What am I saying? A patient is on DTG, you do their 6 months viral load, it's suppressed, and they've never been on TB preventative treatment, you can give them 3HP. In other words, 3HP is only contraindicated in newly diagnosed HIV positive patients who are on TLD. But the same patient 6 months later, when the viral load is suppressed, you can give them this weekly high dose INH with rifampicin, 12 doses, and then they are able to complete. We have discussed this. If you are transitioning a patient from efavirenz to DTG, make sure that they are suppressed, only start 3HP 2 weeks later. What am I trying to address? I'm not trying to teach you today TB preventative treatments. I'm trying to make you aware that we initiate ARVs first. We don't make regimen choices after we have decided on a TB preventative treatment. You must choose your patient's regimen first and say, the best regimen for my patient Thabo is TLD. Therefore, 3HP is out, right? You must use your clinical assessment first. And don't say we have a better TB preventative treatment. You start your patients on it and you give everyone TEE. And when you say, why didn't you give them TLD? You say, no, but I wanted to give 3HP. No, don't do it like that. So I hope those who are from Gauteng, City of Joburg, eThekwini, OR Tambo, eThekwini, right? That you follow and you do the right thing, right? So I hope that is clear. All right, so quite important. We're addressing a lot of things. And I think if you are attending today and maybe this is your first attendance of an HIV seminar, this might be too much, right? Because the webinar is trying to address specific things and it might sound a bit complicated, but do enroll for basic HIV courses so that you can understand the basics, because here we are trying to deal with issues around how we make decisions around the regimens, particularly TLD versus TEE. Here is Donna now. We are continuing, right? Now we are looking at Donna. Donna is a 26-year-old female. She presents to you. She is HIV infected. Her weight is 54 kgs and she has a CD4 count of 89. So she's not there. She's quite sick. Ne? She was treated for cryptococcal meningitis 6 weeks ago. She is currently 3 weeks pregnant, no active TB, no opportunistic infections at present. She's also taking cotrimoxazole and fluconazole prophylaxis without any side effects, right? Absorb the case. It's a young woman, she's 3 weeks pregnant, recently discharged for treatment of meningitis. She's not healthy because her CD4 count is 89, the weight is 54. She's okay today clinically, but she's also on these 2 drugs, cotrimoxazole and fluconazole prophylaxis. So yeah, let's engage. It's getting interesting, you know, as we get closer to closer. Right, today's session is a bit long, so you've got 2 CPD points because we might finish presenting around 30:30 and then maybe engaging with your questions. So let's see. Remember to get your CPD points, 60 minutes per point, right? If you attend less, yeah. So she's pregnant, she's young, she's 3 weeks pregnant. What are your drug options for this lady? Okay, I'm gonna give you 5 more seconds to get a sense of where you are. And then we take it from there. There's more than 700 of you, so it's an important topic. Thank you again for participating and for joining. We have reached the 50% voting. I'm going to stop and I'm going to show you your results. So I see Most of us are saying tenofovir, lamivudine, and dolutegravir. So can we use dolutegravir in pregnancy? In early pregnancy, she's 3 weeks pregnant. Is that the reason why some of us are saying, no, dolutegravir, we are going to use efavirenz here because dolutegravir is teratogenic, it causes spina bifida and anencephaly and all sorts of things, right? So yeah, so I see most of you chose TLD. So remember, we are saying TLD or TEE. So most of you are saying TLD, but there's like 10% of you who are saying TEE. So let's look at what the guidelines say, and I'm hoping to share some data with you as well. So I start here, and I want to tell you, because remember, if you don't know, Dr. Mawela is very passionate about pregnancy and HIV, and I believe that we should do our best to prevent HIV transmission to women before they even fall pregnant. It's the first rule. Increase access to family planning to avoid unplanned pregnancies, provide ARVs as soon as possible, and support. But there is a problem which you are looking at here. Look at non-pregnancy related infections. Look at South Africa there. So a third of all maternal deaths, right, are contributory or are because of non-pregnancy related infections. HIV particularly being involved, right? The opportunistic infections that are making these deaths to continue to rise. TB, pneumonia, PCP, cryptococcal meningitis. These are all HIV associated infections, right? So it's very important to start here. When we talk about which regimen to choose in pregnancy, you must start by understanding that HIV is a big problem in pregnancy, contributing to a third of all maternal deaths, women who die when they are pregnant because of HIV, right? Now, when you understand that HIV can kill women in pregnancy, and you have a pregnant mom in front of you today, what is the best drug combination to quickly suppress the viral load, helping us not only to keep the mom healthy, but to give birth to an HIV negative child at the end? What is the drug combination that is known to be able to improve or increase your CD4 count rapidly from the baseline CD4 count? That is my question to you. And if you answer that, then you know which drug regimen is recommended in pregnancy. So firstly, ensure that every pregnant mom is tested for HIV. If they test positive, make sure that it is confirmed. You provide post-test counseling. Baseline assessments are done, which must include a gene expert for TB, and that women, regardless of whether they are in the first trimester, second trimester, last trimester, that they are initiated on ART same day. No woman who tests positive when she's pregnant must leave your consultation room without some form of ARVs. Even when you suspect contraindications, you must give an alternate ART regimen, right? We don't wait for blood results. In pregnancy, ART initiation is an emergency, because I told you what HIV does in pregnancy, and there's a baby as well whom we want the child to be born, as negative as much as we can do, right? So you assess them clinically, you exclude drug interactions, you do your urine dipsticks, your creatinines. If you suspect renal failure or renal issues, you want to give a drug combination, maybe with abacavir, but she must not leave your consultation room without some form of ARV cover. This is quite important. And also note the integration between HIV and women's health, or the antenatal care package. Let's not treat HIV in our corners and forget that she's pregnant, or when she's seen by midwife, you do all your basic antenatal care services, but you forget to initiate ARVs. Let's integrate and make sure that our women get the best care they can. So what is the preferred standard first-line regimen in pregnancy? It is TLD, tenofovir, lamivudine with dolutegravir. Why? Because the suppression of a viral load is an urgent matter in pregnancy, right? It's urgent. Women to reconstitute and get their CD4 counts going up, it's urgent, because if we are not careful, she's going to have TB in pregnancy, cryptococcal meningitis in pregnancy. Where there's an absolute contraindication to one of the drugs, let's say TDF is contraindicated because we suspect that she's got kidney issues, then give her abacavir, lamivudine, and DTG. She must not leave your consultation without some ARV cover. If DTG cannot be given, give her efavirenz or lopinavir, ritonavir. But 99.9% of pregnant women who test positive, they are still healthy and okay. They tested because they felt pregnant. Therefore, TLD is the drug of option. Now, in the survey that I did when we started asking you, what are some of the barriers, for us initiating DTG? Some of you clicked on pregnancy, and so on. And even now, when I said, what is the regimen? Some people pointed at efavirenz because you are worried of these neural tube defects. And yes, if a patient takes DTG, there is still some risk that they may get there's a risk that the child might be born with neural tube defects. This study obviously is a very poor study, because if you look at the confidence intervals, then the power very, very, very weak. But if you look at the actual numbers, one case versus two cases, even in HIV negative patients, what this whole story is trying to tell us is that yes, there is risk, but the risk is generally the same or below what you would get from a normal population, even for patients who are not on ARVs, right? So this is quite important. And this was a publication from the Botswana, the same study, which led to changes in the guidelines, very early on in 2019. This was additional surveillance looking deeper. So this is non-significant data, if I was to be honest with you. And there's a lot of confounding factors, which I will discuss later when I show you further studies. Now, here's another report, from Brazil, and you see they included 1,400 women, of which 382 were exposed to dolutegravir in the first trimester, right? And another portion as well to efavirenz. But you also need to note this particular component, that only half of the women in this particular study were on some form of folic acid supplementation. But if you look at the actual dosing, it was even below, the type of levels that we need to reach to prevent NTDs, right? What were the results? There were no neural tube defects in both groups, right? In 1,427 women, no neural tube defects, right? When this study was closed, no neural tube defects. But later on, after the study was closed, there were 2 cases which were confirmed to be having neural tube defects. And I will share with you in the next slide the analysis of these 2 particular case studies. And what is quite common in those 2 case studies, that both women were never on folic supplementation. And if you are in the obstetric world, you know the importance of folic acid supplementation at the right dose, so that you get the right concentrations to prevent neural tube defects, right? So, and it is estimated, if you include these 2 cases that came after the study was closed, the actual incidence, is way below the 1% that you sorry, I think someone is talking and unmuting, so I'm going to give me a few seconds to deal with that. All right. Yeah, so let's all mute. Thank you for that. Yes, so what I was trying, so let's interpret. So neither DTG nor efavirenz exposure in this particular study was associated with neural tube defects. And for the 2 cases which were reported later, the incidence was still less than 1%, which is the WHO standard for this particular scenario. And you can see that if you look at patients who were only on DTG only as a regimen, the risk was actually quite lower. And these ratios are basically used in comparison with what you would get from efavirenz. What do you get from these two studies? Number one is that the risk is there. The risk is quite minimal. There's other confounding or other reasons why women may develop neural tube defects, right? And there's this modeling from Kathleen and the team, and they involve some of the people here in South Africa. And you would see that the results of this particular model suggest that if South Africa opts for an efavirenz regimen versus a DTG regimen, right, this will result in a whole lot of deaths of women. That's number one. 13,000 more deaths among women living with HIV, more than 39,000 more opportunistic infections, and more than 60,000 additional HIV transmissions, including 7,000 to children over 5 years. So you need to appreciate that the choice of DTG for pregnant women goes way beyond just the issue of whether DTG is risky or not. A choice of efavirenz means that we are going to have more negative impact of women and their children. So it goes beyond when you look at the discussion and the impact of this, of your choice. Like when you have a patient in front of you, she's pregnant, and you opt for efavirenz, you need to remember what you are contributing towards, right? Death and mortality, more admissions because of infections, and HIV transmission because efavirenz is quite a weak drug, you know, a poor barrier to resistance, etc., right? So what do we know? What do we know at this point in time? We know that a deficiency in folic acid at the completion, at conception until the neural tube closure, especially the first 6 weeks, we know it. There's evidence from before DTG that is a significant contributor to neural tube defects. Hence, those two cases, both those reported cases in the Brazil study, there was zero folic acid supplementation, right? The same Botswana study now, which is very important, the same study which made a lot of noise and we ended up changing guidelines and saying no DTG, the follow-up and the further evaluation of that study actually came back and said, actually the risk of neural tube defects between comparing DTG and efavirenz is the same. So they have the same risk. In other words, you cannot use neural tube defects as a decision point as to whether you're going to give efavirenz or DTG, right? I mean, I'm over convincing you, but I'm hoping, you know, you are following. In Europe, where there's an antiretroviral pregnancy registries, particularly North America, Europe, and Latin America, you know, where these particular countries have adopted folate fortification for their food. So there you have a population level folate, you know, fortification. Even before you are pregnant, the food you eat already has folate. You know, in these particular countries, they have never observed an increased risk of neural tube defects with DTG, right? So this is what we know. And based on what we know, the WHO came out and said, now DTG is a preferred HIV treatment option for all populations, adults, children, women, whether they are planning to fall pregnant or not, whether she is on family planning or not. If she's pregnant, all trimesters, first trimester, second trimester, third trimester, irrespective of when she presents. If she tests positive, your regimen that you initiate should have DTG unless you have absolute contraindications to the use of DTG in that particular pregnancy. All right. Now, South Africa followed, and you can see this was written, it was referenced last year, you know, around June, to say updated guidance on the use of DTG in pregnancy. And I'll summarize it to say DTG for all women. DTG for all women, right? For all women. So whether pregnant or not, whether planning to have a baby next year or not, whether on long-term, short-term hormonal contraceptives or not, in pregnancy, all trimesters, there is no place for other regimens in pregnancy, unless there is an absolute contraindication to DTG for that particular patient. You know, I really pray that you have heard me on this one. Can you comment in the chat and say, yes, doctor, we are convinced on this one? If you are not convinced, say you are not, then I know me and you, we must have a one-on-one Zoom conversation. Can you confirm for me in the chat there and say, yes, 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 doc? It's clear. Thanks, Tembela. I think Tembela is on board. I see Nomvelo, Judith, Anthea, Mpo there. Good, 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 good. Everyone, I'm happy, you know, that you are following. Mara, I see you there. Hey, you guys are typing so fast. I can't acknowledge all of you, but I'm hoping we are all on the same page. And I tell you, South Africa has a lot of health workers, probably close to 1 million, and there's only 700 of us here today. I'm asking you that I'm going to share the recording, I'm going to share the video, I mean the slides. Please do in-service trainings where you work. George, Vagis, I see you. You know, go and do, because it's not enough. It's not enough that it's only you who's getting this information. So we need to all participate in this. Now, I'm a very passionate person about PMTCT. I can't give a whole talk on PMTCT. I can just give you this slide to tell you that PMTCT is a complex program. There's the pre-pregnancy things we must do, like keeping women negative, increasing access to family planning, testing women regularly, you know, access to pre-exposure prophylaxis. When they are pregnant, we must diagnose the pregnancy as soon as possible by universally doing pregnancy testing. Every time you consult a female, do a pregnancy test. Start ARVs quickly, check the viral load, make sure she's suppressed, deal with a high viral load, provide support. If a baby is born from a mother, provide high-risk prophylaxis, at least until you have confirmed the delivery viral load. So PMTCT is a topic on its own, but this slide includes key interventions which we need to really, you know, pay attention to. So I'm hoping that it will help you when you get these slides. Right. Please sip some water like me, because I want us to continue with our so what have we covered so far? We have said that a stable HIV positive patient, TLD, is recommended. A patient who's got TB-HIV co-infection, data tells us that DTG, BD, 50 milligrams BD is as effective, is non-inferior to efavirenz, right, in that particular context. We spoke about drug-drug interactions and how to deal with those in the context of TLD or DTG as well. We were now talking about a pregnant woman who tests positive. What is the best regimen? And we acknowledge that HIV is a killer in pregnancy. Therefore, they need the best regimen which can suppress the viral load quickly and reconstitute the CD4 count, and that is TLD. Now, look at Donna now. Donna is back, right? So you have initiated her on TLD. She comes back. She says, hi, doctor. I'm gaining too much weight. I am gaining too much weight, doctor. And she's not happy. And someone asked about this question. I said we will reply. I will reply to it. So let's deal with it. But before I deal with it, can I give you a chance to engage with this particular question? So she's 2 months on TLD and she complains of weight gain. I mean, what would be, you can choose more than one option, but what are some of the things you think might be your plan? You know, there's things that you can never go wrong. All right. I know I think our time is catching up with us. It's a 2-hour session. That's why we said 2 CPD points, but I'm hoping to finish around 1:30 so that we can engage further. All right, so I'm going to stop. Sorry about that. If you didn't participate, my apologies. And then here we are. Most of you say reassure the patient, refer to a dietitian. I must also investigate and manage the cause, advise the patient on lifestyle modification. Then some of you want to switch DTG to efavirenz or DTG to lopinavir. You know lopinavir, one of the side effects of lopinavir is central obesity, truncal obesity, the same one, same shape as what you will get from DTG associated with cardiovascular risk. So I'm not sure, which one is better. Efavirenz as well, patients can gain weight. There's also a theory that actually most patients who gain weight from DTG, it's after the transition from efavirenz to DTG. So when you pull out that efavirenz there, it slows down the metabolism of food, and then somehow patients gain weight. So there's a lot of theories really, more than answers. But let me share with you some few things, and then maybe that will enlighten you as well, and then I can hear your views. So here are some of the common side effects when you take a TLD or DTG: nausea, diarrhea. Insomnia for me is more common, maybe with the headache, in terms of my own experience, right? And when I engage with patients, they tend to have difficulty in sleeping. So we then say, no, take it in the morning, and then usually they're okay, and then there's this looming thing around weight gain, which I will talk about. So you see, again, your GI, diarrhea. But if you look at, firstly, I need you to appreciate these rates, right? That firstly, DTG associated side effects are rare. Let's start there. They are rare. And when they do happen, they are mild, right? 1 or 2 patients really might fail to cope, but most patients tolerate this drug like magic. Hence, when you compare it with other regimens, you've got fewer discontinuations from patients who are starting DTG. So this is quite important. Another side effect is that you might get a slight increase in creatinine levels. This is non-pathological. If it's DTG associated, it is non-pathological. It's mainly because of the transportation of creatinine between the renal tubules on the proximal tubule there. But it never, so the creatinine never rises above 15% from the baseline, So if it was 100 when you started TLD, it will never go above 115, because that's like a 15% kind of increase there. And also it increases and it stays there. If you see an increase and there's an ongoing increase, you should evaluate other causes, hypertension, diabetes, check if this is not tenofovir associated nephrotoxicity. So like I said, DTG, non-pathological. And here's the slide. And, I'm just sharing, and I'm thinking we will invite Prof. Francois Fender from WRHI to come and share with us just on weight gain in HIV broadly. And I think we will get a lot of insights from him, but you can check this particular article about dolutegravir. And here they were trying to compare prodrugs of tenofovir, TEF and TDF, and to look at how DTG performs. And the weight gain finding was incidental. So this particular study was not designed to detect and monitor weight gain, but weight gain was an incidental finding as part of the monitoring, of the trial. And what you see, particularly, I know it's small print. So firstly, there's the standard of care. So if you give an alternate regimen that does not have dolutegravir, there's still weight gain, but over 48 weeks, they are gaining like 1 kg, there's 0.5 kgs, right? And we are comparing males and females up there. And then the 2 regimens, the tenofovir that we use mostly in the public sector there. And then in orange, it's TEF. TEF is a prodrug of TDF, which has like a better side effect profile, and so on. And what do you see? Number one is that patients on DTG general, whether TDF or TEF, have significant weight gains, even in the just over 1 year. You see, females can gain up to 6.4 kgs in the first year of taking a DTG-based regimen. And this is very significant, right? But also it seems like those who are on TEF and DTG versus TDF and DTG, are having a significant rise. So it affects more females than males, and it is also regimen specific. But a common denominator on all these regimens is dolutegravir, right? So the risk factors are a female. There's an issue about ethnicity, though in the study for males, particularly for males, gender was not a risk factor. I mean, ethnicity was not a risk factor. Patients who are starting ARVs at a low CD4 count, high viral load at an older age, were at a higher risk. And obviously, if you are on TEF versus TDF, your risk was higher. So those are the risk factors. In other words, if you find a patient who's got these risk factors, you have to start before they even gain weight. At the start here, you have to start dealing with lifestyle modification, and ensuring that they go to a nutritionist, and physical activity is also encouraged, and so on. Now, weight gain, particularly during pregnancy, was explored by Caniglia, and the team as looking at the same Botswana cohort, the Tsepamo team. And you can see that in this analysis, which included 1,683 women on DTG, 1,400 were on efavirenz, right? And then 1,600 were on DTG, I think. And they compared them with HIV uninfected women. And you see that women on both DTG and efavirenz gained less weight during pregnancy compared to uninfected people. So it seems like in pregnancy, this weight gain is not very apparent, right? DTG was associated with a decreased risk of insufficient weight gain. So it's neither here nor there, but all in all, we can sort of conclude that DTG and efavirenz in pregnancy, not significant weight gain, though DTG slight in this context. As you see, the language used there is not a very easy one to consume. A different study as well looked at gestational diabetes to say, fine, if these drugs can cause a weight gain, does this lead to metabolic changes? And we are looking at the pregnancy, by the way, gestational diabetes, and you can see that 8.4 women had gestational diabetes, and this was similar between those living with HIV and those who were negative, right? And for the patients living with HIV who were on DTG, they actually had a lower risk of getting gestational diabetes. So this was quite, encouraging a bit, but we are still a bit worried. So what can you do based on what we know? Remember, what we know is the risk factors is from this particular study that yes, DTG in non-pregnant females contributes to significant weight gain, and these are the risk factors. So what can you do? Institute a lifestyle modification for all patients at the start of ART. Investigate, like maybe for our patient who's pregnant, it's unlikely to be DTG. So we need to investigate whether this is just pregnancy-related weight gain, or she had lost significant weight at the time of starting ART. Therefore, she's gaining weight because she's happier, she's healthy, and manage as needed. We must monitor for cardiovascular disease, implement an interdisciplinary approach, and maybe include dietetics and nutrition, reassure your patient, and continue the same regimen. If the viral load is suppressed and you are dealing with this type of a patient where in 48 weeks she's already gained 10 kgs or something like that, and she's worried, use a person-centered approach. If she says, I'm fed up, I don't want this treatment, I want something else, we don't have a lot of drugs to switch to. You're going to switch to efavirenz, which can still lead to weight gain, but what we are hoping for is that we might have newer and better drugs in the future. For now, there isn't much that we can do. It's a condition that we need to learn to live with, right? So for tonight, I'm going to close with issues around children and TLD, and then I think this would be the second last section. So please bear with us. It's a 2-hour session, but I want to sum it up shortly in the next few minutes. So in terms of children, here we have a 9-year-old HIV positive child, so 9, weighing 32 kgs, and then the CD4 count is 300 cells, and then the child was also diagnosed with shingles. So it's a not so healthy child, you know. If you have this type of a child, do you have a preferred drug choices? Do you have preferred drug choices? What would be your drug choice for a 9-year-old who weighs 30 kgs? Superb. Okay, a few seconds, continue voting. Continue voting. I'm going to stop in 5 seconds time. 5, 4, 3, 2, 1. Yes, thank you for that. So, yeah, I can't tell, you know, from this to say which one, but it seems like most people believe that abacavir, dolutegravir, and lamivudine. I think that's what most of us think, though there's those who think tenofovir. So what's the challenge with tenofovir? You cannot use tenofovir on any child who's less than 10 years old or who has a weight below 35 kg. So tenofovir is out. Lopinavir, yeah, you know, it's there, but I think there's better drugs that we can use. Efavirenz is there, but there's better drugs we can use. So TLD, again, is probably the best option in this case scenario. So this is the summary of preferred first-line ART regimens. Remember where we are dealing with a child who's more than 20 kgs, but less than 35 kgs. So our child, Leseho, belongs to this particular group of children. And then the child's age is also less than 10 years. So we can't go to TDF, right? We stick here. So if you were to choose the drug choice, it will be abacavir, lamivudine, and DTG. You would then go to the dosing chart. I'm sorry, it's fine print because I was trying to squeeze it on the slide, but we chose abacavir, lamivudine, and dolutegravir there, right? The weight is around, what was the weight? 32 kgs. So we are on this small thin block there, right? So if you use abacavir, the adult dose, 300 BD or even 600 daily is what is viable. And then you give your lamivudine 300 milligrams per BD. I mean daily, sorry about that. So let me start again. Abacavir 600 milligrams daily, lamivudine 300 milligrams daily. But you have an option to use a fixed dose combination, which has the 600 and the 300. So 600 abacavir and 300 milligrams of lamivudine. So basically, you could use the fixed dose combination there. You go straight to your DTG and you use DTG 50 milligrams. So basically, this child, there's a possibility that this child may get 2 tablets, right? Just the fixed dose of abacavir and lamivudine, which is 1 tablet, the adult tablet, plus your dolutegravir 50 milligrams. So 2 tablets, but it all depends on whether this child is able to swallow tablets or not. Otherwise, then you have to look at the pediatric version. I think there's the 120/60 and see how many you can give, or even, you know, taking the smaller tablet, the 150 milligrams, and taking it twice a day. But in terms of prescription, it's abacavir 600 milligrams daily, lamivudine 300 milligrams daily. These 2, give them as a fixed dose combination with your dolutegravir in blue there, 50 milligrams once daily. So that is, you know, when it comes to children, you know, it is as simple as that. Now, here's a different scenario. And this one, there's no polling question. I just want to address something which is complex to address today because the guidelines are about to change, but I'm hoping you'll understand where we are going with this. So let's read it together. It's John. John is a child. He is 5 years old. He's weighing 24 kgs, right? And comes to you. He had pulmonary TB when he was 2 years old. Otherwise, his vitals are okay. He's growing well. He's currently taking a regimen that has abacavir 2 mils BD, lamivudine 15 mils BD, lopinavir, ritonavir 3 mils BD per os. And here are the review, the review blood results. At baseline, he had a CD4 count of 20%, 6 months, the viral load was suppressed. 12 months on ART, the viral load went up and the CD4 count dropped. 18 months, the viral load dropped at least to 4,000. And then the last one, which is your 24-month viral load, it was for 48, depending on the machine. 48 can be interpreted as suppressed. Those are machines will count from 25. So the last viral load looks good there. The grandmother confirms that the child is okay, no other problems. They don't miss appointments, but the mother says John sometimes spews the medicine, right? So there is that complaint there that when they give him the medicine, he spews. And I would understand why, because this lopinavir, ritonavir solution or syrup, if you taste it once, you would know why this child is like this. So how would you make, the child's life easier? What are some of the things you might want to do? You may comment in the chat box there. You are looking at a child who's relatively suppressed today. Rose says pellets. All right, Rose, someone says, okay, no, such a different question. Share it in the Q&A box. Change to DTG. Is that Trompo? All right, can give peanut butter, yes, to deal with the taste. Pellets. So let me go back. Let's go back to help you a bit. Let's go back to this dosing chart. Yeah, so when I see yogurt on your comment, you are saying let's deal with the taste. Some people say let's change the drugs. Some people say replace. Let's give a better formulation for lopinavir. I'm going to close the chart because I want you to focus on this dosing chart. So we are here. The child weighs 24. So it's not even this block. It's this. Remember, the child weighs 24 kgs. They're giving the child the syrups, abacavir 10 mils, lamivudine 15 mils, and then the lopinavir, ritonavir there. I know it's small, but there's 3 mils there. Some of you are saying, let's keep the lopinavir, but let's give 6 capsules BD of these pellets. So the mother must open, remember, these are not supposed to be swallowed. They must open them, mix with yogurt, 6 of them. I wonder how big of a spoon is that? So it's going to be a bit cumbersome, right? Maybe the pediatric tablets, 2 of those tablets, BD, maybe that's what we need to do, But you can also simplify the abacavir, 10 mils maybe to the 60 milligram tablet, right? Because 10 mils in a syringe is too much, and it's still BD. If you want to give this 10 mils as a once daily, you must give 20 mils once daily. No, it's too much. Look at the lamivudine there. If you want to give it as a daily dose to improve adherence and simplify it, it's 30 mils. It's too much. It's too much. So maybe move to capsules or tablets and that. But I want to share a few things and I'll tell you my answer towards the end, because this is the last few slides. This time I promise. We are actually almost done. This is the last part. Remember, in terms of the themes, I said I want to discuss the use of DTG on first line. So now I need you to grasp the concept that things are changing. Things are changing. DTG can now be used as part of first line or second line ART regimen. And I get a lot of calls with my colleagues, the doctors and nurses, saying, I have a patient who's got side effects from lopinavir. I just ask, what is the viral load? If you tell me that the viral load is suppressed, I tell you, well, stop lopinavir and give DTG, even if it's part of second line, So the key message here is that DTG is now available to be used as part of first line and second line. So if you've got a patient who is in need of second line and you want to simplify the regimen, DTG is available as long as there are no contraindications to the use of DTG for that. Now, before I move on to the next slide, obviously we are at the crossroads, and I must explain it now, because if you read our guidelines as they are today, they will tell you that in terms of second line, you may transition any patient from lopinavir to DTG as long as they are on a standard second line. So if someone is taking zidovudine, lamivudine with lopinavir, ritonavir, the guidelines will say you can transition those patients to DTG, right? And then if a patient is taking tenofovir, lamivudine with lopinavir, ritonavir, the guidelines will say don't transition them. And the reason why there was such a thinking, I'll explain it now. It was because at the time when the guidelines were written, we knew that for you to give dolutegravir, one of your NRTIs, especially zidovudine or TDF, needs to be active. Right? You should not give DTG to patients where they've previously failed your NRTIs at that particular time. So that was the story, and the recommendation from the guidelines was that if a patient is taking zidovudine, lamivudine, and lopinavir, ritonavir, their viral load is suppressed and there's no history of failing zidovudine, you can stop lopinavir and give them DTG, and they will take zidovudine, lamivudine, and DTG, and that's that, The guidelines would then say, if a patient is on a non-standard second-line regimen, tenofovir, emtricitabine, and lopinavir, the guidelines will say, don't transition, don't give DTG, because we don't know if TDF is still an active NRTI. And as I speak to you, this is the guideline. The guideline allows DTG to be used as first line, which is what I explained up until now, But it also allows for DTG to be used as second line as long as you're talking about a suppressed patient who is taking, a standard second line regimen. You can easily transition. But if they're taking tenofovir or other things, you shouldn't, right? And obviously the requirement is that the viral load must be suppressed. If a patient has a high viral load, don't do single drug switches, deal with the high viral load and then decide how you want to move, forward. Now, the change, it's because there's a update in a number of clinical trials. And I won't go into detail. There's the Nadia trial, there's the Vicent trial, and there's also the ARTIST study. These three studies have confirmed an important finding. And the finding is that, and let me go back. The finding of these trials is that even if a patient is on a non-standard second-line regimen, even if they are failing TDF there, you can still use DTG, right? That is what these studies are saying. Now, I want to give you advice. You'll hear a lot when you call centers and many people telling you, no, you can recycle, you can still use DTG. Our guidelines from the public sector have not changed. Obviously, this document you're looking at is from the South African HIV Clinician Society. It was published late, is it this week? What day is it today? Yeah, late last week, I think Thursday, Friday, it was published. And it means now they are saying as a society, patients who are failing first line, when you take them to second line, you can still keep DTG. But I want to say to you, our government guidelines have not changed, right? So DTG can be used on first line as second line. On second line, only if a patient is on a non-standard first line regimen. But watch the space. I think in the next few weeks to a month, you will get a communication from the National Department of Health reviewing the use of DTG and allowing you to use DTG even for patients where the NRTI backbone might be compromised. This is the HIV world. That's why some of us, we love it, because you shouldn't be comfortable. You are comfortable with one principle. Tomorrow there's a new study. That principle does not apply anymore, and it keeps us on our toes. So to remind you again of our patient who weighs 24 kgs, she belongs here. Unfortunately, she's still taking abacavir, lamivudine, and lopinavir as syrups. She's spewing, there's adherence issues, the viral load keeps going up. Luckily, at this point in time, her viral load is below 50 copies. Therefore, we can simplify the regimen by giving a fixed dose combination of abacavir and lamivudine there, then stop the lopinavir and give the child DTG 50 milligrams, and all the taste issues that the grandmother is complaining about would be gone. And I think that is really the message I want to share with you. And also to say, there's a pediatric formulation of DTG which is coming, and watch the space. Very soon you'll be able to give DTG to children with even lower weight. So don't get fixed on old concepts. Transform yourself, but let us be patient and allow the review of science to be completed nationally. Once our guidelines have been reviewed, you do that. But the private sector, I think a society that represents mostly the private sector has already published that you may use DTG and with the same NRTIs that you would have used on your first line regimen. And I think that is fine. So what can you do for our child, John? Enhanced adherence counseling is your first step. Simplify the regimen, switch solutions to capsules, transition lopinavir to DTG because the viral load is relatively suppressed. Educate the grandma about the new drugs, and then monitor and repeat the viral load. So as I now do in summary and in conclusion with these two slides, DTG is an integrase inhibitor. The full name is dolutegravir. The short name is DTG. The dosage is 50 milligrams daily. It should never be given alone, but it must be given in a combination with NRTIs. Most of the time, it will be TLD, so very, very key. It is now recommended for both first line and second line for all people living with HIV and AIDS, including women of childbearing potential, whether on family planning or not, including in all women who are pregnant in all trimesters, first trimester, second trimester, third trimester. Pay attention to drug-drug interactions, know how to handle a patient who's taking other drugs and know what adjustments you need to do. Some side effects are common, for example, insomnia, but the patient can be advised to take the drug in the morning. Weight gain is starting to become an issue. Monitor your patient's weight, BMIs, start your healthy lifestyle campaigns very early, refer them to nutrition as early as you initiate ARVs so that your patients can really do well. In conclusion, TLD is superior to TEE because TLD has dolutegravir, which provides rapid viral suppression, well-tolerated, fewer treatment interruptions. It is available as a fixed dose combination, easy to take, a high barrier to resistance, no interaction with hormonal contraceptives. However, there's always risks in terms of drug interactions and the weight gain. Let's continue to watch the space until we know exactly how to handle this. All right, so yeah, it's a 2 CPD event. I think I've managed to put together, a full package which you can use, for your own learning, but also share it with other people. The chat is open there. You may share how you feel about today's session. Let me maybe for 5 minutes look at the questions that maybe were not addressed in this. I see most of them have been addressed. What is the main reason why the viral load is not done? The viewer, it's cost in the public sector. So if we can afford, we could do more. It's nothing but cost. And you can actually manage a patient, even if you don't know what the baseline viral load is. Can I switch a patient who is stable with a high CD4 count and viral load from TEE to TLD? Yes, Omar, you may switch from TEE to TLD, but the viral load needs to be suppressed, for now, because that's what the guidelines say. But I know there's a number of changes. This Nadia study changes a lot of things around how we think about our patients there. What can you recommend for a patient who missed a chance of the booster? Now the viral load is super high. The guidelines, any patient who develops a high viral load because we didn't boost either lopinavir or DTG, a viral load resistance test is indicated, Thandeka. So discuss with your lab and then do a virological test to confirm whether there's mutations or not. Yes. So DTG, TLD can be taken in the morning or in the evening. It doesn't matter. So I think that one we have addressed. How do you manage a newly diagnosed patient with TB culture positive mode, but gene expert is negative? You must take the culture as a true reflection because gene experts have a low sensitivity in HIV positive patients. Your TB culture is the gold standard, so that patient needs to be treated for TB. Talk to the lab because mods they are broad. You know, you need to give specific treatment based on the type of TB bacilli that they are going to grow, right? Patient on nevirapine develops TB, stop nevirapine, give a DTG. If DTG is contraindicated, give efavirenz. Duduzile Mabena, thank you for attending. I'm happy to see that you have enjoyed the session. Yes, tomorrow expect an email. I'll be sharing the slides. You know, expect when TB is suspected, then they say, okay, yeah, some of these are comments based on the questions that I was talking about. Please ensure that, okay, Marilyn, Tyra, please ensure that everyone realizes the importance of excluding hepatitis B. Yeah, it was a bit beyond my scope for today, Marilyn, because I had so much to cover, but the hepatitis B, HIV co-infection, quite a common finding. Make sure that you don't stop TDF and lamivudine in those particular patients. Marilyn, you are saying efavirenz has serious neuropsychiatric side effects. DTG is associated as well, suicidal. All right, Marilyn, I see you are sharing your experience. Yeah, but you know, from studies, we haven't found that DTG has a lot of neuropsychiatric, but we can never say never. I think you'll deal with it on a patient by patient basis. So yeah. I think the issue of a rising creatinine clearance in the context of TLD, I've explained it that if it's dolutegravir associated, it doesn't continue to rise. Then you should investigate other causes and consider if that is not associated with tenofovir. Doctor, please clarify for me, why is it that some clients who default or with a very low CD4 count don't make it after reinitiation? Yeah, so you have to take proper history. You must reassess. Remember, if you have a low CD4 count, you are a time bomb. They might be having extra pulmonary TB, cryptococcus, meningitis, disseminated herpes simplex, hepatitis B. When you start ARVs, then they get what we call an IRIS, an exaggerated inflammatory response. Your role there is to investigate, find that bug and treat the bug, you know, because if you fail to diagnose the condition, you won't be able to initiate proper treatment. Nevirapine should never be given with TB treatment. I think we agree on that one. Janine, currently under review by the National Department. Yes, regards. Oh, yes, thank you, Janine Jukspal, for that comment that there's a review, you know, around the new developments. It was quite a difficult topic to touch because one knows what needs to happen, but one must respect the review process. So colleagues, remember I said, let's adhere to the current guidelines until we get a proper guideline that advises us how to move forward with regards to some of the studies that have published good results so far.